Hello, good evening. This is Dr. Karen Sullivan, board certified neuropsychologist. Very happy to be with you here at I Care for Your Brain. Every week I try to bring you a free, interesting, informative brain health lecture to make your experience as a brain health challenge survivor, thriver, the very best that it can be. Tonight we are going to talk about a topic that is very near and dear to my heart, and a conversation I have had hundreds, if not thousands of times with my patients and their families, and it is how to get a loved one to accept care. These are very delicate conversations that require a lot of empathy and patience and respect, but far too frequently, people are not having any instruction whatsoever on how to go about making these conversations respectful and successful. So this was inspired by a conversation I overheard last week while I was on vacation. A woman literally walked by me and said to her friend, "My mother doesn't want anyone in the house, but if we don't do something soon, I know my dad is just going to decline. He hasn't been visiting his friends. He doesn't go out to get breakfast with his neighbor anymore. And he even canceled a physical he had with his primary care doctor last week because he doesn't want to leave my mom alone. If we can't get care in the house for her, we're going to have to do something," meaning probably put her into a facility. So this is a very typical scenario. People are really left with a lot of questions on how to do it right. So not only do I think I can help you as a neuropsychologist, but I was a home care provider from the time I was about 15, 16 to 21. So I have 5 to 6 years of being the caregiver who came into the home. U.S. home care is done by companions, certified nursing assistants, home health aides, friends, family, neighbors. It really does take a village. And it's just basically describing someone coming into the home to help with 3 different scenarios. The first one is safety. The second one is care needs. And the third one is companionship. In 2015, the number of people in the U.S. who received home care was 4.5 million. And this is an industry that has expanded by about 44% in the last 5 years. And mostly that has to do with the number of older people living in the world above 65 is pretty much doubling as we get closer to 2060. Moreover, when you start to poll people as they age, more and more people are saying, "I want to age in place. I want to stay in my home," which makes a lot of sense because care facilities have a long way to go to be desirable to more and more people. What these statistics are not very good about telling us is the psychological process of what it takes to accept this care, except when someone tells us that you need a little bit of help. So home care typically becomes an issue in one of 2 ways. Very quickly after something like an accident or an event like a stroke or a traumatic brain injury, or it's a need that is obvious over many, many months, if not years, but finally people get to a point where as a caregiver, they can't do it anymore. A safety issue happens. Someone has a fall. Someone comes to the front door and they get let in, and they, financially exploit the person. When we start to think about needing care, it typically falls under one of 2 categories. The first one is help with what we call your basic activities of daily living. So this is typically like getting dressed, making food, making sure someone doesn't fall when they get in and out of the shower, those kind of things. Then we also think about instrumental activities of daily living, which are kind of a step above. This is making sure someone's medications are being done correctly, making sure that they can get to and from where they need to without driving, and making sure that they are paying their bills, handling their money. So when people need help in either one of those 2 areas, home care can be a good idea. And also companionship. This is probably thought of as the least pressing of the 3, but in reality, we really shouldn't think of it that way. Loneliness is an epidemic. And oftentimes when we tell older people that they can't drive or they shouldn't drive safely, for many people, it really creates a lot of social isolation because they can't get out and do anything anymore. So many times when I was a companion, I was really just there as a safe person with a car who would take the person to and from where they wanted to go. So that loss of independence didn't sting quite so much. So what we're really talking about in these conversations is acceptance. So there's really two things that need to be accepted in this conversation. The first and the hardest one is that care is needed, that the person is not quite functioning at the level that we need them to for safety or for their basic care needs. The second one is accepting that a professional caregiver is the one who should be doing this. Sometimes you can get people to move on, okay, yes, I need someone to be here, but they may want it to be you. They want it to be the spouse, the daughter, the neighbor. What we have to understand in many of these situations is that it is a medical condition that is creating the care need. And so if you really think about it like that, it can help recognize that you need a medical professional with training to come in and successfully take care of this person. Many care needs involve a lot of physicality, getting people up and down from bed, getting them in and out of the shower. There's a lot of risk to a caregiver in, pulling out your back, slipping yourself. So at a certain point, it becomes obvious that we need someone who actually has some formal training in doing this. The greatest barrier towards accepting care, in my experience, and partially it's because I work with people who have cognitive impairment, specifically dementia, is a loss of insight or a lack of awareness that the help is actually needed. And this is most common as it relates to a subtype of dementia called Alzheimer's disease, one of the most common types. But it is a neurological symptom. It's very easy to feel like this is a psychological defensiveness, and that the person just doesn't, want to admit they need help. And that can be very frustrating because you wind up banging your head against the wall, having the conversation over and over. The truth is, especially if it's Alzheimer's, the person may just not see it in the same way that you do. So very important that you really get into a conversation with the person, especially if they don't have any cognitive issues, to understand what are their feelings about it. And so that really leads me to my two kind of goalposts as I'm thinking about this conversation. Is the very best approach is always going to offer these two things. The first one is developing the plan with as much say and control from that person that is appropriate and reasonable to that person's mental clarity. Okay, the clearer someone is, the more reasonable they are, the more we can include them in the conversation. As people get more and more impaired, or they become poor decision makers, or don't have the insight to realize the safety risks that are there, the more we have to help develop the plan. But in either situation, the earlier the better. Okay. The other part is that we always want to lead with empathy. We always want to think about, what is it like to be on the other side of this conversation? What is it like to be in your 70s or 80s and need care? What is it like to have been healthy one day, in your 30s, and all of a sudden you have catastrophic stroke and now you need a companion or a caregiver with you there every day? So we really want to lead with empathy and respect. And so the first thing I want you to think about is getting clear on why the person needs help, even making a list and thinking about safety needs, care needs, and companionship. That can really help. Then I want you to assess the degree of cognitive impairment. How in tune is the person who needs the help with the reality of the situation? If they're clear and they get it, then this is when you can have a back and forth conversation that is rational and reasoned, when you can explain, this is how I see it, this is where I think you need some support, and these are the risks. This is what I'm afraid could happen if we don't get you a little bit more care and support. And the way I want you to frame this conversation is that they may actually have an opportunity to be more independent and more happy and engaged in life with someone there to kind of plug up the holes. So you really want to make sure that you are emphasizing the abilities that will come to the person by having more help. And I know that's a little bit counterintuitive, but you really have to kind of see it that way. You have to figure out what matters to them. So what is their pain point? So what I mean by this is, if they're isolated and you have heard them say things like, I'm lonely, or you don't come around enough, or, I'm bored, that's the need that they have articulated for them that is lacking. So that's where you want to go after. If somebody is really struggling with being a fall risk or being maybe too weak to get up and down from the couch by themselves, you can emphasize the exercises that the home health aide might be able to do to get them stronger. If they complain that they're tired of eating microwave meals, you can talk about how someone in the house could make them some home cooked meals. You have to really try to find the person's pain point and really focus on that. That's how you're going to be most successful. If they push back and they have concerns, listen to them and be reasonable and truthful. You have to be honest that you believe that this care is needed, but you also have to have some degree of flexibility and responsiveness to their resistance. Many people can feel that it's an invasion of their privacy, and you can acknowledge that. Yes, I get that to some degree. I would be uncomfortable at first too, but the alternative to getting home care is for many people going to live in a facility. And so you kind of always have to be ready to get real about if we don't follow plan A, plan B might actually be less appealing to you. So you really want to emphasize what the alternative would be. And really, I think going with safety oftentimes is where most people can reason. If you can't get them to see the benefit of the home care, or they have more cognitive impairment than allows them to see, then you really have to start to realize that you are in the position of being the decision maker. And that's a very tough transition when you've been in a relationship with someone for years, decades, where you make decisions together. This reminds me, of spouses. Even more so if you're in a relationship where it's kind of like mom and you, or, older sibling and you, where they've kind of always been the leader. It can be really weird to start to shift the power and start to make decisions for that person. But you sometimes have to do that. And that is very tough, and you should get support around that. But we can't bring such an important decision to someone who has cognitive impairment, who's not seeing it. And I'm talking about now people with advanced dementia. We want to, of course, include them as much as we can. But again, sometimes their disease is what's going to be the resistance. It's not even the person. So if we decide that we're moving in that category, we have to really think about for ourselves, what is the responsibility that we now have. Now, one thing I will tell you is that no matter why a caregiver comes to the house, the benefit of socialization and connection is always going to be there. And that is really the isolation that can come along with aging, the isolation that comes along with a brain health challenge. That is really a killer for people. And it's a hard thing to admit. There's a vulnerability in saying I'm lonely, or, I feel sad when I'm here by myself. But make sure you make that a part of the conversation. And what I can tell you is when you're thinking about a caregiver coming into the house, that's still kind of abstract. And it's hard to imagine that someone could attach to a stranger. But even after one visit with someone, it goes from being a caregiver to being Karen that comes and visits. And that transition, once you can get past that first visit, is oftentimes a huge difference when you can refer to that person by name. You can also bring in the doctor. This is what the doctor recommended. I tell people all the time, I'll write a note for the refrigerator. Dr. Sullivan says you need home care. So that way, if they forget, it's not always on the family member to kind of be the bad guy. We need doctors to be more involved with shaping these kind of decisions. Many times people are worried about the money, and that is very valid. Only recently have some Medicare Advantage plans in the US supported home care, okay? And so oftentimes people pay out of pocket. So the first thing is to call the person's insurance and see what benefits they have. If someone is a veteran in the US and they have served in the military, please call your local VA. Even if they've never gotten any care from the VA, there are pretty good benefits for home care for a lot of our veterans. Now, again, if the person is cognitively impaired and they're pushing back, because this is the reality, part of the change you can make in your approach is not over-explaining it. You don't have to go on and on, tell them far in advance, get them to agree. You can really not belabor the point, keep it short and sweet. If you tell a person too early, it typically only leads to anticipatory anxiety, but you are going to start to have to make decisions for them. So once you're in that realm, okay, so now I'm thinking of people with advanced impairment, this is where the therapeutic white lies can kind of come in. You can talk about the person could help with housework. You can say something like, I need them to come in and do things around the house, or I need them to come sit with you. I don't feel safe unless someone is here. Again, I want us to stay in this home together. I want you to be able to age here, but we're not going to be able to do that unless we get someone to come over and help you with the laundry because it's really piling up. It's really important to, even when you keep it short and sweet, just try to keep it as respectful and include that person in the decision as much as possible. You don't have to say how many days they're coming. We often have this very loving, inclusive part of ourselves where we feel like the person should know. We want them to understand what's happening. But in the case of dementia, you can oftentimes just add to anxiety and agitation. So once you kind of know you're in more of that severe category, you can just set up a visit with a caregiver and have them come to the home and talk to them ahead of time and try to prep them for what would be the best approach for your loved one. So many older people are very social. It's a much more social generation than currently people who are in their 20s to their 30s or 40s. And they respond very well to welcoming pleasantries. So you can make sure maybe the agency or the friend of a friend who's coming knows that you want them to be really, really friendly. You want them to be very welcoming. Help them understand things that have been meaningful and important in your loved one's life. Who are their favorite sports teams? Where were they born? Where did they go to college? Is there a musician they like? Do they speak any other languages? Where's been their favorite vacation? These are the things that they're going to be able to find common ground on. And home care workers and people who need care first have to find connection. That is the most important thing. And then it's like any other healthy therapeutic relationship. It can grow once there is common ground there. So be comfortable directing the caregiver, telling them ahead of time, these are the things I'd like you to do. Now, it does get dicey because sometimes some caregivers feel like I am just here to help with the care of the person. I don't do dishes. I don't do laundry. And, that's to be respected. But if that's the only way you can get someone in the house, you can say to them, hey, could I pay you $10 more if you would just do a couple dishes in the sink? If I had a load of laundry that needs to be folded, would you just sit here and do it in front of him? Because we need him to see that you're working and you're here to do housework. At least at first, we need him to see that there's value in you being here because he doesn't himself think that he needs the care, okay? You can also reach out to the agency if you go through someone and say, hey, this is my first rodeo, but it's not yours. How do I make this transition more successful? Some of my favorite companies do a kind of like a matching process in terms of the person's likes and personality with the caregiver. So what is ideal is, again, if someone is a Spanish speaking person, wow, if we could get someone in the house who was Spanish speaking or bilingual, that would just be an immediate form of connection. Always remember that humor and being human and all of the basic things all of us like, having the person's favorite cookies available for when the person comes, have their blueberry pie ready for them to share and to meet with the caregiver. Finding ways to just create more empathy and connection is really at the heart of when these things go well. I would love to hear your thoughts on these comments. If there's a trick that you have that would help any of our other learners here on Facebook, I would be most grateful if you would write it in the comments. If you found this information helpful or thought-provoking, I would be so appreciative if you would share it far and wide on Facebook. We're also on YouTube under the same name, I Care for Your Brain. And most importantly, if you haven't followed our page here on Facebook, please do that. We are about 75 people shy of being at 10,000 followers, which our 5-year anniversary is in late July. And boy, wouldn't that be awesome to get to 10,000 right around that time. So thank you all so much. I have a couple other lectures planned for over the summer. I'm looking at ataxia. I'm looking at primary progressive aphasia. I'm looking at strategies for getting smell back after COVID. If there's anything that you would love to hear me talk about, please just drop me a line in the comments. Thank you all so much, and I'll see you soon. Bye-bye.